Good evening, everyone. Welcome to First Aid AMC MCQ 2 weeks free session. How are you all? Okay, so let's start our tonight session. So we have been doing cardiology, right? And we finished our first class on cardiology. And today we are supposed to finish our rest of the cardiology. So far, do you guys have any question in our previous session? All right, so seems like you're all okay and you understood everything that we have discussed. So let's start our cardiology class 2. So tonight we are mainly focusing on few of the other topics that's important. And let's start with, so I know that we have discussed a little bit about how the heart works, right? Let's have a look on this video just to see that, because we are going to start with congestive cardiac failure, and you need to know how the heart works. So just to recapitulate the heart pathophysiology, anatomy, everything, let's watch this video first. Okay.
A healthy heart, as seen here, beats approximately 60 to 100 times a minute, providing oxygen-rich blood to the rest of the body. The lower left chamber of the heart, called the left ventricle, is the main pumping chamber. There are many different conditions that can lead to congestive heart failure, including a prior heart attack, high blood pressure, and coronary artery disease. Any of these can prevent the heart from efficiently pumping blood to the rest of the body. As a result, the heart may beat faster and the ventricle may increase in size, becoming an even less effective pump. When the kidneys sense the reduced blood flow, they attempt to compensate by retaining more water and salt. This excess fluid retention often causes congestion in the tissues and results in swelling and an increased strain on an already weak heart. The progressive effect of the heart failing to properly circulate blood and congestion due to fluid retention is known as congestive heart failure.
Okay, so there's a very good understanding about congestive cardiac failure, how that works and everything, right? Now, even a little bit more better discussion is needed. So let's have a look how actually heart failure happens and what are the main symptoms we get and why we get them. So let me just open another slide so that I can show it to you. All right, so let's see that this is your heart. And we know that our heart has got 4 chambers. And we discussed this a little bit last class as well. So blood will come from superior vena cava and inferior vena cava in your right atrium. And then through the tricuspid valve, it goes to the right ventricle. And through right ventricle, it will go to the lungs through the pulmonary artery. So all of these bloods, until reaching into the lungs, they are deoxygenated blood. In the lungs, they are going to get oxygenated, and then those oxygenated blood will go to the left atrium. And then from the left atrium through the mitral valve, it will go to the left ventricle. And then from left ventricle through the aorta, it will go to the whole body. Right? So this is how it works. Now, heart failure can be several types. It can be systolic heart failure, diastolic heart failure. It can be right-sided heart failure, left-sided heart failure, right? Now, the most commonly, the one that we use is systolic heart failure and diastolic heart failure. Now, what is systole? Systole is the first heart sound that you listen on cardiac auscultation, that heart sound coincides with the contraction of the heart. So when heart contracts, to push the blood from the left ventricle into the aorta. That's systole. And then after systole, heart gets relaxed. So heart will then get relaxed so that it can take all the bloods from the extremities. And that relaxation is what we call as diastole. Now, heart failure can happen if there is a problem with systole. So if contraction is not happening properly, or if diastole, that means relaxation, is not happening properly. And what is heart failure? It means your heart is unable to pump enough blood to your body. And if the pumping action itself is not working, that means it's a systolic heart failure. And if the heart is not getting enough blood, how it can pump enough blood to your body, right? So that's diastolic heart failure. Now that you know about these two, let's talk about left heart failure and right heart failure. Left heart failure starts with problem in the left ventricle. So if let's say that someone's left ventricle is not working properly, so maybe acute myocardial infarction, arrhythmia, a lot of things can cause this. If left heart is not pushing blood out, left ventricle will start to get filled with blood, and at one point it will start to become thicker and thicker so that it can push more blood. But once it becomes thicker, the power of the muscle gets weaker. So even though the muscle getting thicker and larger, the pumping action is not that better. So at one point, left ventricle becomes full of blood. So that will get pushed back. So it will push backwards, and it will then starts to accumulate in your left atrium. Okay. So left atrium now starting to get full with blood. At one point, left atrium will be full. So then what will happen? It will cause more backlog of blood. So now the blood will go into the pulmonary vein, and through the pulmonary vein, blood will start to get accumulated into the lungs. When blood starts to accumulate in the lungs, that is what we call as pulmonary edema. All of you should know about that pulmonary edema due to acute left ventricular failure. Now you know how it occurs, right? So if there is an acute left heart failure, that will cause pulmonary edema. So that is what we call as pulmonary edema due to left heart failure. Now, if there is fluid accumulation in the lung, what will be the finding in the patient? So patient will come to you with shortness of breath. Patient will have bibasilar crepitation. So you will be able to hear the bibasal creps on the lungs. And sometimes you can get some gallop rhythm like S3 gallop rhythm as well. But the main presentation of pulmonary edema is a severe worsening of breathing difficulty. And if you examine the patient's lung, you'll get bibasal creps. Now, at one point, the lung will get full of blood. And what it will do, it will cause more pressure over the pulmonary artery. So pulmonary artery then starts to get more blood pressure, and that's what we call as pulmonary hypertension. Okay? When there is more and more pulmonary artery pressure, what will happen to the right ventricle? Now, right ventricle needs to push blood against excessive pressure in the pulmonary artery, right? So if right ventricle needs to work harder, what will happen to the right ventricle? It will become more and more thicker. And at one point, the same thing that happened with left ventricle, it will also happen with the right ventricle. So at one point, right ventricle will also become weaker. That will cause more pushing of blood into the right atrium. At one point, right atrium will get full, and then the problem begins with congestive cardiac failure, which means now the bloods that is supposed to come from your upper extremity through the superior vena cava, now it can't do that. So you get a raised JVP. Then blood starts to get accumulated in your lower extremity because it can't get into the right atrium. So there is peripheral edema, right? Because this inferior vena cava also taking blood from the liver. So that also gets restricted. So hepatic congestion happens, and you can get a tender hepatomegaly in congestive cardiac failure. Then you can start to get fluid accumulation in the peritoneum, causing ascites. So all of this is just due to backlogging of bloods, because your heart is not able to pump enough blood to the body. Okay, so raised JVP, peripheral edema, ascites, hepatic congestion causing tender hepatomegaly. These are all the features of right heart failure, or in short, we can call the whole thing as a congestive cardiac failure. Is it making sense for everyone, guys? I know it's a lot of drawing and everything, but this is the main pathophysiology of heart failure, and everything about heart is very interesting. If you understand it, it is not very hard to understand, right? Anyone is still confused about how the heart failure works and how the symptoms that we discuss about heart failure, like how it happens? Everything clear? Okay, very good. Now we will move into our heart failure discussion. So a 60-year-old man presents to his primary care physician for several months of dyspnea on exertion, exercise intolerance, lower extremity swelling. He has a past history of sarcoidosis. On physical exam, he has JVP, raised, pitting edema in the lower extremities, and the echo shows ejection fraction of 35%. So ejection fraction 35% means that heart is not pumping enough blood, right? So you can obviously understand from this term that there is dyspnea on exertion, exercise intolerance, peripheral edema, right? JVP is raised. So all of this already going with heart failure. So this is how the heart failure patient usually will present to you. So there are two things, case 1 and case 2. Let's read that, and then you will understand which one is systolic heart failure and which one is diastolic heart failure. Now, before we discuss that, systolic heart failure means that heart is not able to pump enough blood into the aorta and into the whole body. And this pumping action is what determines the ejection fraction. So ejection fraction is dependent on how much blood your heart is able to pump out, which is the cardiac output. So in which heart failure ejection fraction will be low? Systolic or diastolic? Systolic, right? So it means that systolic heart failure patient's ejection fraction will be low. Even by looking at that, you will know that what kind of heart failure this patient is having. So you can see in here a 62-year-old man having history of hypertension, dyslipidemia, presents with dyspnea and lower extremity edema for 2 months. There is raised JVP, S3 gallop rhythm, apical impulse is displaced, chest X-ray shows enlarged cardiac silhouette, and the echo shows a dilated left ventricle with an ejection fraction of 35%. So ejection fraction, ideally it should be above 45. Sometimes even we say between 50 to 70 is fine, but nowadays we say that 45 to 65% is ideal. Okay, but even up to 50, we can say it is normal. So for exam purpose, there is no specific value that I can give you, but let's say 50 to 65%, that is usually the normal ejection fraction. So this patient obviously has got a low ejection fraction, which means it is systolic heart failure. Have a look on this one, a 57-year-old having multiple myeloma, presents with dyspnea and lower extremity edema for 2 months. Raised JVP, S4 rhythm or S4 heart sound. Apical impulse is non-displaced. Chest X-ray shows normal cardiac silhouette, And the echo shows a thickened left ventricle with an ejection fraction of 65%. So see the difference between these two. In systolic heart failure, your left ventricle, it gets dilated because it tries its hard to make its muscle hypertrophied so that it can push some blood out. So in that process, usually the left ventricle gets dilated. If left ventricle gets dilated, apical impulse, so this is the apex, right? So apical impulse will be displaced and you will get an enlarged cardiac shadow on a chest X-ray. But in patients with problem with relaxation, they don't get this problem. They don't have a problem with the left ventricle dilation. They don't have apical impulse displacement, and they will also have a normal cardiac shadow on chest X-ray. The only problem is that they can't relax properly. Okay, and their ejection fraction is fine because it's not the problem with systole. The problem is with relaxation. Now, symptoms in summary. So, in patients with heart failure, they usually present with shortness of breath, so dyspnea, because of most of the time it is because of fluid accumulation, heart is not pumping enough blood, so patient will become dyspneic. Orthopnea. So orthopnea is when shortness of breath occurs after lying down. Now you understand that when the patient is at upright position, fluid goes into the dependent areas, which means maybe lower leg, maybe sacral edema you can get. But when patient lies down, all the bloods actually will go to the lungs as part of gravity. So the patient usually gets increasingly short of breath after they are lying down. That's orthopnea, classic picture of left heart failure. Some patients can also, obviously, they can get wet. Weight gain can happen because of fluid accumulation, fatigue, lethargy, dry, irritating cough, ankle edema, hepatic discomfort, or abdominal discomfort because of hepatic congestion. Now, some of you ask about heart sound. Heart sound is not important for exam. The only thing that you need to know from heart sound is S1 and S2 heart sound is just a normal heart sound. Everyone has it. So S1 is systole, and the heart sound that you hear after the systole is S2. If someone has got S3 gallop rhythm, that's sometimes you get in heart failure patient. Same, you can also get S4, which is also another abnormal heart sound in heart failure patient. Okay, that's the only thing that you need to know for this. Now, moving on. So let me finish, then you can ask about these heart failure questions, because most of the time your answers or your questions will be answered by the discussion. So left heart failure and right heart failure, what are the main symptoms that we look for? In left heart failure, as I said, patients usually get pulmonary edema. So their main features will be shortness of breath on exertion, shortness of breath that get worse after lying down, and you can get a bibasilar crepitation and a S3 gallop rhythm. That's the main feature. How about right heart failure? Right heart failure, the main feature is all the accumulation of fluid features. So raised JVP, peripheral edema, hepatomegaly. What are the physical findings that we look for in heart failure? We already talked about it. We look for bibasilar crepitation, ascites, peripheral edema, hepatomegaly, raised JVP, all of those, even sometimes ascites. Systolic versus diastolic heart failure. So we already know that systolic heart failure is because of inadequate pumping action of the heart. And it means that if heart doesn't pump adequately, the ventricle gets dilated and it doesn't contract properly. And that's why the ejection fraction becomes low. Diastolic heart failure is due to impairment of the left ventricular filling, which means that it can't get properly relaxed, but it has a preserved systolic function. So systolic function is fine, which means ejection fraction will be normal in these patients. Now, diastolic heart failure is not very common. Systolic heart failure is more common. But diastolic heart failure should be considered in patient who is elderly, having hypertension, and a normal heart size on a chest X-ray, who will present to you with shortness of breath and a pulmonary edema. So elderly patient having hypertension, having shortness of breath, especially during exertion, and you have done a chest X-ray showing normal heart size, you have done an echocardiogram, echo shows normal ejection fraction, but that might be the case of a diastolic heart failure. Okay. So this is from your Kaplan step to CK. You can go through this. So we discussed about that ejection fraction will be less than 45% in systolic heart failure. So what are the causes of systolic heart failure? Most of the time it could be like myocardial infarction. Sometimes even severely uncontrolled hypertension can cause it. Sometimes even some cardiomyopathy, like ischemic cardiomyopathy, dilated cardiomyopathy, they can also cause this. We will come to the discussion of this later on. Now, this is from JM, causes of heart failure. You can see that systolic heart failure is caused by ischemic heart disease, including previous myocardial infarction is the most common cause. Approximately 2/3 systolic heart failure is caused by ischemic heart disease. And sometimes essential hypertension is also one of the other causes. Whereas diastolic heart failure, most commonly it could be also ischemic heart disease, it could be hypertension, aortic stenosis, atrial fibrillation, hypertrophic cardiomyopathy, lots of other causes, even sometimes obesity, diabetes, that can be a risk factor for diastolic hypertension. Diastolic heart failure. But as you can see, the most common cause of heart failure is ischemic heart disease and then hypertension. So that's a basic idea about heart failure. Now, coming into the next thing, which is what is your investigations if you suspect a patient to have heart failure? So my questions to all of you, that if you have got a patient who is presenting to you with heart failure symptoms, what is your initial or next most appropriate investigation? ECG, very good. Okay, so all of you are on the right track then, because many students used to say echocardiogram as the initial investigation. But now I can see that obviously you improved a lot, which means that always remember, a patient coming to you with features of heart related problem, you would not directly take them for an echocardiogram, never. So you do a ECG first, and after having the ECG, then if you suspect this patient has got a heart failure, then you would do a echocardiogram. So ECG is a must at first. So the exam questions actually make you confused like this. So they will give you a heart failure scenario and they will ask you, what is your next most appropriate investigation? And next most means initial. So initial will be ECG. What we can get in ECG? Sometimes we can get, let's say, we can get, if there is any ischemic heart disease, we can get that. If patient has got any left ventricular hypertrophy, any arrhythmias, anything abnormal, we can get just by a simple ECG also. Now, if the question asks, what is your most appropriate investigation in that patient? What is your confirmatory investigation? What is your best investigation? That will become echocardiogram. Okay. So echo is our most appropriate or best investigation for heart failure. Now, what is the role of doing a chest X-ray? Not much, but as an adjunctive or as an adjunct investigation, you can do a chest X-ray, but it's not very important as part of heart failure diagnosis. Now, there is one other test that you can do in a heart failure patient to check the progress of heart failure, not to diagnose heart failure, but to check how the heart failure is progressing, if the medication that you are giving, if it is working or not. So what's that? Yes, BNP. So BNP is called B, B-type natriuretic peptide. So BNP is a very good investigation. It's not an investigation to diagnose heart failure. Remember that. Because many candidate thinks that, well, why we would do a echocardiogram where we can get a blood test and find out about it. We never do BNP to diagnose heart failure. Once you diagnose heart failure, if you want to know how the patient is progressing, then you can do BNP. Okay, so it is an indicator of severity of congestive cardiac failure, and also it gives the prognosis of heart failure. Yes, Dr. Sana, that's right. So ECG is the initial test and echo is the confirmatory. Yes, that's also another thing, Dr. Muid, very good. If by any chance you are in a rural area or you are in an area where echo is not possible, then yes, you can do a BNP. Okay, so that's our last resort that we can try. But obviously, if echo is possible, then we would not choose BNP. So echocardiogram is the test of choice to confirm the diagnosis of heart failure, and also it can give you the type of heart failure. So if it is systolic heart failure or diastolic heart failure. Now come to the treatment. So heart failure treatment, it has a stepwise approach. You just don't give everything initially. So first of all, for any heart failure patient, especially for systolic heart failure patient, your first line treatment would be ACE inhibitor or ARB. So either a ACE inhibitor or ARB will be your first line medication. With that, if patient having congestion, let's say patient having peripheral edema and patient having lots of edema everywhere in the body, then you add furosemide. If just with furosemide it is not working, then you will add spironolactone. And if it is still patient having congestion, then you can add a selective beta blocker. Only time you can add a beta blocker if the patient's heart failure is well controlled. In a decompensated heart failure, we don't start beta blocker. And even after beta blocker, if that's not helping, you can try digoxin. Okay, so this is the step-by-step approach. Now, ACE inhibitor, furosemide, spironolactone, beta blocker, digoxin. Digoxin is nowadays not our favorable medication to give to the patient. We try not to give this because of a lot of side effect it has. There are other medications that can be tried in heart failure. Can anyone tell me that, let's say you have tried ACE inhibitor, furosemide, spironolactone, beta blocker, but still patient's heart failure is not well controlled. Is there a medication that we can try? Entresto. Very, very good. So I can see all of you is saying few of the important things. Dr. Savin, Eva Bradin, very good. Entresto is very good. Not empagliflozins also sometimes can be given, but not the first line medication, we would say. So few of the other things that can be used is, first of all, if a patient's heart failure is severe, okay, so like very severe, ejection fraction is going down to 25%, and especially if it is less than 35%, in those situations, you can add ARNI. So ARNI is one of the very good medication for heart failure. Nowadays, we use it. So ARNI is angiotensin receptor neprilysin inhibitor. So ARNI. So this helps the heart failure by keeping the blood vessels from constricting. So, and this ARNI is what is Entresto. It has valsartan, so that's the ARB, and it has sacubitril. Okay, I know it is a little bit hard for you to get, but just remember ARNI, and the medication under ARNI at the moment is valsartan and sacubitril. This is usually will be given in a patient who you have tried with ACE inhibitor, furosemide, spironolactone, and a beta blocker. Still, patient is not getting better, or heart failure is very severe. Ejection fraction is down to 25, 15. In those cases, you have to add Entresto, which is your ARNI. Now, some of you talked about glyphlogens or empagliflozin. Empagliflozins is a very good medication which you can try, but empagliflozin is a diabetic medication, and sometimes this is the only diabetic medication which also protects the heart. But many times we have seen that even without diabetes, we give this glyphlogen to the heart failure patient. So that's also one of the other options. And sometimes even you can try ivabradine. And these are all the medication which is given in a patient with severely low ejection fraction. Okay. Now, digoxin will not be our best option anymore. So I would not give digoxin. I would rather start with ACE inhibitor or ARB, then try furosemide, spironolactone, and also a beta blocker. If this doesn't help, then I would go for a ARNI. And with ARNI also, we will add the glyphlogen at the same time. And sometimes, like, obviously, we don't give we will stop this selective beta blocker and we will start the patient with ivabradine. So it depends on a lot of other things, but only thing that you need to know is that there is few new medications which can be tried for heart failure at the moment. Okay. So ACE inhibitor, diuretics. Diuretics only needed if a patient is having fluid overload, not in other cases. And when patient's heart failure is stable, you can add a beta blocker. This diuretic is the furosemide. If furosemide doesn't work, then we use the aldosterone antagonist, which is your spironolactone. If that doesn't help, then you can start with ARNI, ivabradine, or empagliflozins. Okay, so this will be your step-by-step approach. Now let's have a look with this interesting topic. So did you guys get an idea that what will be the step-by-step management for heart failure? They usually don't ask you when to add ARNI or ivabradine because those are a specialist level knowledge. And in AMC, as long as you know that what is your first line investigation, which is ACE or ARB, then we would add a furosemide if patient is having fluid overload. Then if needed, we add a spironolactone. If patient is euvolemic, which means no more congested, then a beta blocker. And even after that, if we need something, then we have those options. Do we need to remember the doses of drugs? No. As you can see, I haven't said any doses so far, which means that doses are not needed, just the name of the medication. Now, beta blocker. Beta blocker is a very important part of heart failure therapy. Along with the ACE inhibitor, beta blocker have been demonstrated to decrease the mortality, reduce the hospitalization, improve the functional class. Now, see in here, start patients on beta blocker after stabilization of symptoms with diuretic and ACE inhibitor, irrespective of blood pressure. Beta blockers such as carvedilol, metoprolol, bisoprolol have been demonstrated to have some benefit. Now, why we can't use beta blocker in a patient who has got decompensated heart failure? Anyone? What beta blocker does? It reduces the heart rate. Now, what is the main issue with systolic heart failure? Main issue with the systolic heart failure is that it can't pump blood. Now, if you reduce the heart rate, on the top of when heart is struggling to push blood out, obviously it will just get worse. Okay, so we don't want the heart to overwork where it is already struggling a lot. So that's why we would not give beta blocker in a patient who is having a compensated, like who is having like congestion, severely decompensated heart failure. In those patients, we would just wait. Once with diuretics and everything, the fluid volume will become euvolemic, then you can start. Okay. Next, diastolic heart failure. Diastolic heart failure, most of the time, management depends on treatment of the cause. So if patient is having uncontrolled hypertension, you have to treat that, and others. Now, the treatment is a bit different from systolic. So treatment is with ionotropic agents such as calcium channel blocker and beta blocker. So what is the main problem with diastole? Heart cannot relax, right? So you have to give some time for the heart to relax. So, and which medication can do that? The medication which can reduce the heart rate and reduce the contractility, right? So the two medication which works best in this case is rate limiting calcium channel blocker, which is verapamil, diltiazem, and any of the cardioprotective beta blocker. Is this clear for everyone that why we are choosing calcium channel blocker and beta blocker in diastolic heart failure? Now, it is better to avoid diuretics in this patient, except patient is having congestion or any vasodilators. Why? So why we would not use diuretics in this patient? Nifedipine will not be the best because it doesn't reduce the heart rate like those verapamil and diltiazem does. So amlodipine, nifedipine, those will not be the management for a diastolic heart failure, only these two, verapamil or diltiazem. So tell me why we can't use diuretics in diastole. We can't use diuretics because what's the problem with diastolic heart failure? Heart is not filling up with blood. Now, if you give diuretics, you're already losing bloods and fluid with that, right? So if you make the patient volume depleted with diuretics, on the top of that, heart is not able to fill up. So you can just make it worse. So that's why diuretics, vasodilators, those are not very commonly used in this diastolic heart failure patient. And always remember that these are the three medications: ACE inhibitor, beta blocker, and spironolactone. They have shown survival benefit in congestive cardiac failure. So these questions come in the exam that which of the following heart failure medication has survival benefit in a patient with severe heart failure. So you have to remember these are the three medications which has survival benefit and it reduces mortality. about heart failure. So as we can see the tips, echocardiogram is the gold standard to diagnose congestive cardiac failure. We talked about ACE inhibitor is the first line management for heart failure in systolic heart failure. Primary reason for prescribing an ACE inhibitor is to reduce the risk of death. Okay. Now, some of the other thing that we haven't discussed so far in congestive cardiac failure. So we already know that congestive cardiac failure means patient getting fluid accumulation all over the body. And most of the time, a patient can also present to you with pulmonary edema features. That's one of the other important thing. Now, when a patient is having congestion, you have to start the patient with some diuretics. And these are the common diuretics that we have. So we have thiazide diuretics, indapamide, loop diuretics, and potassium sparing diuretics. Now, so one question, ACE inhibitor, beta blocker, spironolactone, these improve the survival benefit? Yes, not empagliflozin. Empagliflozin does, but as part of the best three, these are the best three. And also, yes, EMPA has some survival benefit as well. Okay, now thiazide diuretics. These diuretics also comes with a lot of complications. And these pharmacological complications, drug interactions are very, very favorite in the exam. You will get a lot of questions in terms of side effect of medication, drug and drug interactions. So just the common medications, you should know their side effects. So for thiazide diuretics, the most common complications is it can cause low sodium, low potassium, but it can increase the calcium. It can increase the uric acid. So if a patient having gout, that can make it worse, because gout patients, if they have high uric acid, it will just make worse. This can also cause glucose intolerance. So for diabetic patient, it is not a very good medication. It can also cause agranulocytosis or pancreatitis. Indapamide is also similar like thiazide diuretics, but the side effects are not very common like this. But indapamide is also a common cause of hyponatremia. Loop diuretics, which is furosemide, bumetanide. So loop diuretics, the common complications are everything gets low. So hyponatremia, hypokalemia, hypocalcemia, okay? But one of the important things is that furosemide can cause nephropathy, so interstitial nephritis. It can also cause ototoxicity. Okay, so that means ear problem as well. Potassium sparing diuretics, which is spironolactone. This is the only diuretics which can increase the potassium. So hyperkalemia, and it is one of the commonest medication which causes gynecomastia. So it comes in exam. So they give you a patient coming to you with recent onset gynecomastia, and you will find out patient started with spironolactone maybe a few months ago, and they ask you what is the commonest cause of gynecomastia in this patient. Always drug-induced causes are the first cause that you should think of in the exam. And spironolactone is very commonly, it can cause gynecomastia. And apart from spironolactone, digoxin is also one of the other medication which can cause it. Now, coming to a little bit about digoxin, because digoxin is no longer a very commonly used drug, we are not going into too much detail about it. Just remember how it works. So digoxin is a medication which improve the cardiac contractility. So that's how it can improve the cardiac output, because it increases the cardiac contractility. Okay. Now, the only time nowadays we use this digoxin is if a patient has atrial fibrillation, and with atrial fibrillation, patient has a heart failure, then digoxin still is a good medication to use. So we will come to the atrial fibrillation, those things in our ECG class. But remember one thing, in a patient with atrial fibrillation, the first line medication will be any of the beta blockers such as metoprolol, atenolol, any of those, beta blocker will be your first line medication to reduce the rate. If beta blocker is not helping and that AF patient has got heart failure, that's the commonest time when we would add a digoxin in the patient. Nowadays, this is the sole indication of using digoxin in Australia. Okay, so we try our best not to use it, but still we can see in AF patient, sometimes when they have less ejection fraction, we have to use the digoxin. Okay. Now, why it is not very favorite medication anymore? Because it can cause a lot of side effects, especially it can cause electrolyte disturbance. And also, most importantly, even with a slight increase of dose, patient can end up with a very severe digoxin toxicity. So what are the common symptoms of digoxin toxicity? The most common is nausea, vomiting. Apart from that, patient can have blurry vision, yellow halo around the object. Some patient can get arrhythmia. Remember, digoxin can cause almost any kind of arrhythmia, but the commonest one are paroxysmal atrial tachycardia, premature ventricular complex, and bradycardia. So this arrhythmia palpitation will be discussed in our ECG class later on. Now, one of the important things that I would like you to understand, have a look on this slide, that digoxin inhibits sodium-potassium pump, which results in increased intracellular sodium and decreased exchange of calcium, which causes increase in intracellular calcium. So what actually happens is that sodium potassium pump. So ideally what should happen, there is a receptor here in every cell, and normally sodium will go out and potassium will go in, okay, with this pump. Now digoxin will inhibit this pump. Because of that, there will be more and more sodium inside the cell, and when there is more sodium inside the cell, there is sometimes when sodium goes in, calcium should go out. Okay, sorry, when sodium goes out, calcium also goes out. Now what happens that now, because sodium is staying inside the cell, calcium is also not going out, so there is more and more calcium concentration inside the cell, and calcium can cause increased contractility, and muscular contractility is one of the function of calcium. So it will cause increased intracellular calcium, causing increased contractility. That's not my point. My point is that digoxin competes with potassium to attach with this receptor to go into the cell. Again, digoxin will compete with potassium to add into this receptor to get into the cell. So the problem happens that if a patient has got hyperkalemia, so if there is more and more potassium in your body, then who is strong, potassium or digoxin? Potassium is more strong. So potassium will go inside the cell a lot. Is this clear for everyone so far, that what digoxin and potassium does? So you can see that, remember that potassium and digoxin compete for myocardium binding site. Hyperkalemia will decrease the digoxin activity. So if there is more potassium in your body, then more and more potassium will bound with this receptor, so digoxin cannot bind with it. So there will be reduced activity of digoxin. The problem happens if someone has got hypokalemia. That means if there is low potassium in the body, then who is strong? Digoxin. Digoxin will be added to this receptor, and it will go too much into the cell, and it can cause digoxin toxicity. So the main thing is that if a patient has got hypokalemia, it causes digoxin toxicity. If a patient has got hyperkalemia, it decreases digoxin activity. Is this clear for everyone? Okay, so that's good then. So now if a patient with digoxin toxicity presenting to you with these features of nausea, vomiting, yellow halo around the objects, blurry vision, you have done a ECG, you can see there is some arrhythmia, what will you do? The first thing is you will stop digoxin, and then you try to symptomatically manage the patient. Even with stopping the drug, if still patient having features of toxicity, then you can use a antidote, which is what we call as DG bind. Okay, so DG bind is one of the things that can be used in that case. So that's only thing that you need to know from digoxin. There is also another thing called ICD. So ICD is implantable cardioverter defibrillator. This is one of the last resort for patients who suffer from severe heart failure. So especially patients with ischemic cardiomyopathy, the most common cause of death is arrhythmia. And many patients goes into cardiac arrest. So you give a cardioverter and defibrillator. So whenever heart goes into like ventricular tachycardia VF, this defibrillator will defib the patient. So this is only time we will use this AICD in a patient who has got dilated cardiomyopathy with a ejection fraction less than 35. Okay, you only need to know up to this. There is a lot to know about this AICD, which you don't need to know for your exam. No, cardioversion and defibrillation is a little bit different based on what kind of arrhythmia it is. Like in case of AF, we give cardioversion. In case of VF, we give defibrillation. So we will discuss those things in our ECG class, which will be a part of the course. So we'll discuss that in that time. Now, we have been talking about pulmonary edema a little bit. What is pulmonary edema? It means that the lung is full of fluid, and that is most of the time is due to left ventricular failure. It is a medical emergency because if there is lots of fluid in your lung, it impairs the gas exchange and it ends up a respiratory failure. So any patient who has got pulmonary edema, if you do a X-ray, it will look like this. You can see that it is called, sometimes you can see that how big the heart looks like at the moment. So this is cardiomegaly definitely. And sometimes you can also get this kind of batwing appearance in pulmonary edema. Okay. So in pulmonary edema, patient's main presentation will be shortness of breath, which gets worse, increased respiratory rate, patient can get into cyanosis, all of those. The treatment is admission into the hospital, oxygen, and start the patient with diuretic therapy, which is furosemide. That's the main state of treatment. And some other can be used is that sitting the patient in propped up position, morphine, which can reduce the patient's anxiety, nitroglycerin. Those are the things that can be used later on, but the main treatment is propped up position, oxygen if needed, diuretics. Okay. So that's all about heart failure. Now, we'll be moving on to valvular heart disease. So we take, Dr. Faizia, we take some imaging classes at the end. So those classes will include those Carly B lines and those things. Okay. So moving on, into valvular heart disease. So valvular heart disease, the only thing that you need to know is murmur. And a lot of questions come from these murmur related questions. And there is no one or better way to remember this. You have to memorize all those murmurs. It is hard, but it comes in exam. So you have to memorize those murmur and everything. But I can give you a shortcut, at least to help you with some of the commonly asked murmurs. Okay. So how so? Now, before that, tell me that if you guys have any question with heart failure so far. So the chest X-ray. So the chest X-ray is, you can see, first of all, you can see in pulmonary edema patient, there is increased cardiac shadow, so that's cardiomegaly. And you can also see this bat wing appearance. So bat wing is, it's kind of a wings of a bat, and you can see something like this. That's bat wing appearance, which sometimes we get in left heart failure patient. Without ejection fraction, it is very hard. Without ejection fraction, you can't diagnose a systolic and diastolic just by the symptoms, because symptom will be same. So it is not possible to diagnose a systolic and diastolic just based on symptom. No, nitrate also, because it is a vasodilator, it's not very commonly used for heart failure. Okay, so moving on to valvular heart disease. And we are just discussing some murmur in terms of valvular heart disease. So all of you know about the valves that we have got in our heart, right? So let's just have a look a little bit. So we know that we have got tricuspid valve here. We have got pulmonary valve. We have got mitral valve. And we have got aortic valve. The first thing is you have to know the position of these valves. So where are the positions? If this is the sternum, that's your rib cages, right? So let's say that this is your second intercostal space. It's third, fourth, fifth, sixth. And that's obviously the left side, and that's the right side. So if we draw the heart, it's something like this. Okay? Now, you can see that this is the apex of the heart, which is on the left fifth intercostal space, right? So left fifth intercostal space, that's for mitral valve. And then you have got left fourth intercostal space. You have got left second intercostal space, and you have got right second intercostal space. So these are all the areas of heart valve. So this left second intercostal space, sorry, left fourth intercostal space, that's for tricuspid valve. And then you have got these two, Now you can see in this picture that pulmonary artery, although it starts from the right heart, but it goes towards the left, right? So that's why pulmonary artery, the you will hear it best on the left second intercostal space. So pulmonary valve best in the left second intercostal space. And you can see the aorta, although it is arising from left side, it goes to the right side mostly. That's why on the right second intercostal space, you will hear the aortic murmur best. Now, aortic murmur is a little bit exceptional, and we'll come to that later on. But so far, is this clear for everyone? So mitral valve is left fifth intercostal space, left fourth is tricuspid, left second is pulmonary, right second is aortic. Now, when we discuss about a murmur, you will come across two other things. One is stenosis. So stenosis is narrowing of the heart valve, and then there is regurgitation. Regurgitation means that your heart valves are one-way door. So it is supposed to just take the blood in this direction. But this valve, if it is stopped, if it is defective, the blood will be able to regurgitate back. This is called regurgitation. So you can get either mitral stenosis or you can get mitral regurgitation. Same can happen with any other heart valves. Aortic stenosis, aortic regurgitation. Okay. Now, if you understand this much, we will start with first thing, which is mitral stenosis. You have to memorize the mitral stenosis murmur first. So this is the commonest murmur that asked in the exam. So mid diastolic murmur, best heard on the left fifth intercostal space. So this is a mid diastolic murmur. Now that you know that the MS is a mid diastolic murmur, we can work this to get other common valvular heart disease. How so? So mainly mitral and aortic murmurs come in exam. Okay? And for the purpose of your understanding, remember that aortic murmur is opposite to the mitral murmur. So if MS is mid diastolic murmur, what is the opposite of MS? So M opposite is A, that's aortic, right? And what is opposite of stenosis? Regurgitation, that becomes aortic regurgitation. That's also a diastolic murmur. Okay, and what kind of diastolic murmur it is? It is early diastolic murmur. Now, this was the other thing that I wanted to say to you, that aortic murmur, it is a bit exceptional to this positional problem. Now, aortic stenosis murmur is best heard on this right second intercostal space, whereas aortic regurgitation murmur, it is best heard on the left fourth intercostal space. So this is just a bit confusing, but that's what you need to remember. So aortic regurgitation, it is best heard on the left fourth intercostal. Okay, this is understandable so far, everyone? So how we came up MS and AR? Yeah, and that's from where we have got this ARMS, right? So this ARMS means that is our all the diastolic murmur. So that's how we came up to this mnemonic. Very good, Dr. Afifa. So you can easily remember ARMS, and then you will know that these two are diastolic murmur. Now the other two, So what are the other two? Let's just erase some of this. The other two, we have AMS. So we are left with mitral regurgitation and aortic stenosis. These two are systolic murmur. Now, aortic stenosis is an ejection systolic murmur, and this aortic stenosis murmur is best heard on this area, which is right second intercostal space. And mitral regurgitation is a pansystolic murmur or holosystolic murmur. And interestingly, these two murmur also radiates. Mitral regurgitation murmur, obviously this will best heard on the mitral area. This MR murmur radiates to axilla, and this aortic stenosis murmur radiates to the neck or carotid. Okay? So that's all the important ones. The tricuspid, pulmonary, those are not important for exam, but still, if you can, try to memorize it. But these four murmurs are the most commonly asked murmurs. So aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation. Okay, but I feel it very easy if you can remember in this way. And in the exam, even if you can't remember ARMS, this you will never forget. Okay, so you can easily remember AMS, which is mid-diastolic murmur. And we know that what is the opposite of MS? Mitral opposite is aortic. Stenosis opposite is regurgitation. So that's AR. That's also a diastolic murmur. If it is mid-diastolic, this is early diastolic. And then the other two are systolic. Now about the aortic murmur, aortic stenosis murmur is best heard on the right second intercostal space, whereas aortic regurgitation murmur is best heard on the left fourth intercostal space. So this is all that's given in here. So aortic stenosis is an ejection systolic murmur in the right second intercostal space. Mitral regurgitation, tricuspid, aortic regurgitation, mitral stenosis, and sometimes we get mitral prolapse where you get a mid-systolic click. Now, if you open up these med bullets, they have got all the heart murmurs that you want to know. So I would suggest you that the other murmur, if you want to memorize, then this is a very good guideline, just a very short and concise guideline to remember some of the heart murmurs. So go to the med bullets and you should be able to find it out. Any question, anyone? You're good? Dr. Farhana, if you are a course student, you will get the class notes in our portal. Okay, so let's take a 5-minute break now. And after the break, we will start with some other topics. The only other topic I think we are left with is we're left with some cardiomyopathies, constrictive pericarditis, pericardial effusion. We are left with hypertension. So those will be the main thing that we want to discuss. Okay, 5-minute break. All right, everyone, let's start again. Okay. And some of the question, will we do some revision on ECG? So ECG class is already very, like, there is a lot to discuss on ECG, Dr. Vala. So we'll be doing mainly ECG related classes and also mainly focusing on palpitation and arrhythmia. And Dr. Sana, you said there are 3 survivor drug for CCF is specifically spironolactone, not furosemide. So ACE inhibitor, beta blocker, and spironolactone has survival benefit. Okay. Now we'll be discussing some other topics related to cardiology. So cardiomyopathy. There are 3 kind of cardiomyopathy. One is dilated. Then you have got ischemic cardiomyopathy. You have got restrictive cardiomyopathy. And another one is HOCM, which is hypertrophic obstructive cardiomyopathy. Now, dilated cardiomyopathy, dilated means it's congested, right? So that means the cardiac muscle has got dilated. It's characterized by diminished myocardial contractility involving both ventricle. So what happens in here is that the heart ventricle, because it gets very much dilated, the muscle becomes weaker. So it can't do the contraction. So if the contractility is the problem, what kind of heart failure you will get in this patient? Yes, very good, Faizia Jinat. Systolic heart failure, right? So these patients also suffer from systolic heart failure. The commonest cause of dilated cardiomyopathy is idiopathic. That means we never know what is the cause. The other causes, alcohol is also another common, and then there are some others which you can read. The symptoms will be similar like a heart failure patient. So a patient will come to you with all the heart failure symptoms. If you do a ejection fraction, if you do a echocardiogram, you will find out their ejection fraction is less. So treatment will be same with anyone who has systolic heart failure, so ACE inhibitors and all other things. Now, for dilated cardiomyopathy, if a patient has got less than 35% ejection fraction, then there is an indication of ICD. So you can see this is the normal heart, and that's how the dilated cardiomyopathy looks like. You can see that the heart, the left ventricle has got severely dilated, but on the process of that, see the heart muscle over here and see the heart muscle over here. So it has lost its power. The very important is HOCM, which is HOCM or hypertrophic obstructive cardiomyopathy. It is very important for exam. Lots of questions come from here. So it is supposed to be a hereditary disorder in more than 60% cases, and it is transmitted as an autosomal dominant trait. So what is the main hallmark of this disease? It causes unexplained myocardial hypertrophy, and it causes a thickening of the interventricular septum. If you look over here, you can see, so this is the normal heart. You can see this is the interventricular septum. See on this side, you can see that how hypertrophied it is, and also the left ventricle has got hypertrophic. So when you have got hypertrophic obstructive cardiomyopathy, you get left ventricular hypertrophy as well as interventricular septum hypertrophy. Why we call it obstructive? Because it can obstruct the cardiac flow. You can see that this is the aortic valve, right? And it is almost reducing or almost obstructing the cardiac flow into the aorta. Now, the problem is that you can see that there is lack of cardiac compliance, or because the heart muscle has got very big, there is not much space for the heart to get relaxed and get some blood in. So what kind of heart failure you can get in this patient? Yes, you get diastolic heart failure. Okay, now you can see that heart muscle is like the heart is going to the gym, right? So it will have super strength, and sometimes this patient's ejection fraction is even very higher than normal. Sometimes 80% will be their ejection fraction because there is a very small amount of blood and it's very strong heart. So sometimes the heart becomes hypercontractile, but on that process, it can't relax. If it can't get filled with blood, how it can give more blood to your body? So it causes a diastolic heart failure. So these patients also will present with the same heart failure presentation, dyspnea. Sometimes patient will have like peripheral edema, all the heart failure symptoms. Few things you can get in terms of sign or physical examination. You can get a bifid carotid pulse. You can get a large jugular A wave, S4 gallop. Sometimes even you can get a systolic murmur in the left fourth intercostal space in this patient. Okay, so these are common finding in a HOCM patient. Now sometimes because this can be hereditary, you can get a clue in the exam question that there was a history of sudden cardiac death at a very early age in one of the family members. That's the most common clue to let you understand that this is a HOCM case. Okay, so if you suspect a patient to have this, your initial investigation obviously starts with the ECG. In the ECG, you can get left ventricular hypertrophy, but the best investigation is echocardiogram. It can confirm the diagnosis. The problem is when sometimes if you're doing a resting echo or resting ECG, this hypertrophy might be missed. So let's say that the question is giving in a way that a patient, maybe a 17-year-old patient coming to you with few episodes of blackout, syncope, and you have found that there is a family history of sudden cardiac death. You have done a echocardiogram, which was a resting echo, but it came normal. ECG also normal. You have a strong suspicion for HOCM. What else you can do? Anyone? Very good, Dr. Sarani. A stress echocardiogram. So a stress echo is the indication at that time, because sometimes when the same patient will be doing any exercise or playing, they will show this hypertrophy. So if you are highly suspicious of HOOCM, your resting echo is normal, then before excluding HOCM, at least do a stress echo. Okay. Now, what is the treatment? The treatment is same like diastolic heart failure, which means beta blocker, calcium channel blocker will be your treatment of choice. Okay. Very good. The other cardiomyopathy is restrictive cardiomyopathy, which is not very common. So restrictive is the least common cause, but in this case, the myocardium becomes very rigid. So you can see in here, so your heart needs to be, the muscle needs to be elastic. It can't be rigid or stiff, because at one point it needs to squeeze the blood out, and at other point it needs to relax and take the blood in. Now, if the heart muscle becomes like very stiff, what will happen? It can't do contraction, it can't relax. So this is a condition where the patient gets both systolic and diastolic heart failure. Okay, the presentation is same like how the heart failure patient presents, and the diagnosis also same. You do a ECG, echocardiogram, and there is no known medical management for this. Only treatment is heart transplantation. Okay, so far clear everyone about all the cardiomyopathies? Now, moving on to acute pericarditis. So we have discussed a little bit about pericarditis pain in our first class. So acute pericarditis is also important for exam. It means that if this is the heart has outer covering, which is called pericardium. And sometimes this pericardium can get inflamed, causing a chest pain. So patient will present to you with a sudden onset of retrosternal chest pain, and the pain get worse after lying down and better after leaning forward. It can also get worse with coughing or deep inspiration. If you auscultate the heart, you can find a friction rub, which we call pericardial friction rub, which is a kind of a noisy, scratchy, high-pitched sound on the pericardium, and that is a very highly suggestive of pericarditis. The commonest cause is idiopathic, that means unknown, but many times you can get viral infections causing this. So many patients will give you a preceding viral infection 1 week before this onset. Other than that, connective tissue disorder like rheumatoid arthritis can cause it. Sometimes some of the cancers, uremia like renal failure can cause it. So you will be looking for this. If you suspect acute pericarditis, your next investigation will be an ECG. And the ECG, you will get a diffuse, widespread ST elevation. We will show this in our ECG class. Treatment, it's just treat the underlying cause. But in idiopathic cases, you can treat them with anti-inflammatories such as NSAID, aspirin. If that doesn't help, you can add a steroid. Sometimes even a colchicine can help. Okay, so this is the management of acute pericarditis. Now, acute pericarditis sometimes can get complicated with pericardial effusion. And sometimes even without pericarditis, patient can get pericardial effusion. So what is pericardial effusion? Pericardial effusion is when fluid gets accumulated in the pericardial cavity. So as I have shown you, so there should not be any fluid in this pericardial cavity, but when there is accumulation of fluid there, that is what we call as pericardial effusion. It's just like the pleural effusion. And again, just like pleural effusion, pericardial effusion can be transudative or exudative. And transudative causes are basically if a patient has got heart failure, they can get a transudative cause. If a patient has got tuberculosis, if a patient has got some other causes, then it can also give a exudative pericarditis. Okay. Now let's have a look first. So the pericardial fluid may be a transudate, which we get in congestive cardiac failure, hypoproteinemia, or overhydration. More often, however, pericardial effusion is an exudate reflecting the presence of pericardial injury. But many times, tuberculosis, cancer, those things also can end up having a exudative pericardial effusion. You don't need to know all of this. The only thing that I want you to remember that when fluid accumulates, sometimes it starts to become severely it becomes severe enough that it starts to obstruct the heart. Okay? So when fluid accumulates slowly, the pericardium expands to accommodate it. But when the fluid accumulates rapidly, it can start to compress the heart. And if it compresses the heart cannot get relaxed. And if heart cannot get relaxed, heart feeling or cardiac feeling will be inhibited. And that is what we call as cardiac tamponade. And that's a medical emergency. Okay. Now we'll come to this cardiac tamponade just in a bit. But remember, pericardial effusion, if you want to diagnose this, you have to do an echocardiogram. And echo is able to show you that. If you do a chest X-ray, you'll get a water bottle appearance like this. See that it looks like a water bottle? So that's pericardial effusion. So Cardiac tamponade, it is a life-threatening condition in which a pericardial effusion has developed so rapidly, or it has become so large that now it is compressing the heart, and it causes heart failure also. So a patient will present to you with shortness of breath, fatigue, and orthopnea, just like a heart failure patient. Some other finding is Beck's triad. Very important, this cardiac tamponade comes in exam in various ways. So Beck's triad is patient gets hypotension, raised JVP, so distended neck veins, and a muffled heart sound or decreased heart sound. It is understandable because there is a lot of fluid around the heart, so you will not be able to hear the heart sound that much better. Okay, and because heart feeling is impaired, patient will develop hypotension. Same, what will happen that if heart cannot get relaxed, then the feeling doesn't happen, so there is lots of accumulation of fluid in the neck veins, so there will be distended neck veins for that reason. So distended neck veins, low blood pressure, muffled or reduced heart sound, these are the main features of cardiac tamponade. You can also get pulsus paradoxus in these patients, but this is the main thing that you should look for. If you suspect cardiac tamponade in a patient, the first thing you would do is a bedside echocardiogram, and if echo confirms it is cardiac tamponade, you have to immediately go for pericardiocentesis. So you insert a large bore needle into the pericardium and take all the fluid out. That's pericardiocentesis. Okay, clear everyone with the cardiac tamponade? Are you guys getting me? Like, am I being very fast? Is it difficult to understand me? Anything are you actually enjoying this session? All right, very good. But it is sometimes can be quite tricky because a lot of this you have never read in your life, right? So, but it is easy, and we don't discuss something which is not important for your exam. Next, constrictive pericarditis. Constrictive pericarditis, it is not very commonly asked, but not a bad idea just to have just to know about it. Let's see. So constrictive pericarditis, it is diffuse thickening of the pericardium in response to prior inflammation. Now, constrictive pericarditis, that means pericardium becomes thickened. Now let's say this is the heart and the outer covering is thick. Will it be able to relax like before? No. So it causes reduced distensibility of the cardiac chamber. So if heart cannot relax that much, what it will cause? It can cause diastolic heart failure. Okay. So abnormal diastolic feeling is the main problem in this constrictive pericarditis. Same will happen with this thing. So a patient will have dyspnea on exertion because if heart cannot feel, heart cannot pump out. So there will be shortness of breath. Patient will have all the symptoms of heart failure, as we know. And sometimes, because it is mainly calcification of the pericardium, so sometimes if you do a chest X-ray, you can get this kind of calcification in the heart border. Can you appreciate this calcification over here? So this is called egg on a string appearance on chest X-ray. Let's see if we can show it in here. So egg on a string is a very common finding, and mainly if you will never see this kind of whitish border in any other condition except constrictive pericarditis. Okay, so if you have got a patient who is having this kind of issue, so the only way to understand is that if you do a ECG, X-ray, and a echocardiogram, then you will be able to find this out. The initial investigation for pericarditis. For pericarditis, it is always ECG, and you don't even need an echocardiogram to diagnose pericarditis. But to diagnose pericardial effusion, you will need an echo. Same for a pericardial tamponade or cardiac tamponade, you have to do an echo. All right, so those are the other topics. Now we are moving on to another chapter, and this is our last chapter for cardiology, which is hypertension. So for hypertension, you can open up JM 7th edition 86th chapter, but we are mainly focusing on 8th edition, which is 77th chapter. So first of all, hypertension. So all of you know what is hypertension, but it's still when hypertension question come in exam, you struggle because in your medical practice, you just give any kind of medication, but that's not ideal for exam. Exam has a guideline that you have to follow, a step-by-step approach. Okay, so normal blood pressure is up to, you can see that high normal is up to systolic 139 and diastolic up to 89. So anyone above 140/90 on multiple occasions, that's hypertension. Just a single reading of high blood pressure doesn't indicate that that patient has got hypertension. Patient needs at least 2 settings having a higher blood pressure above 140/90. And then you can see we have also made some grading, mild, moderate, and severe based on the systolic and diastolic. Okay, so if it is above 180 or above 110, that's a severe hypertension. So we say that for adults above 18 and older, hypertension is repeated measurements of diastolic above 19 and or systolic more than 140. Now coming to causes of hypertension, almost 90 to 95% cases, there is no cause. So that is what we call as essential hypertension. And those 5 to 10% which has some cause, these are secondary hypertension. So the cause can be glomerulonephritis, could be renal artery stenosis, very important for exam, could be some endocrine disorder like Conn's syndrome, Cushing syndrome, pheochromocytoma. Patient who is on oral contraceptive can be a cause. Sometimes some of the medications such as NSAIDs and steroids. So these are the ones that you need to remember. Now, when there is secondary hypertension, some of the clinical feature can suggest the likelihood of this condition. Like if you have got a renal bruit, that suggests renal artery stenosis. For glomerulonephritis, if you have got a RBC cast, proteinuria or hematuria, you can think about it. Polycystic kidney disease, patient will get bilateral kidney mass with or without hematuria. And note others are very important. You can go through that later on. So we talked about epigastric or renal bruit suggesting kidney stenosis. Then if there is flank mass, polycystic kidney, delayed femoral pulse or radiofemoral delay suggesting coarctation of aorta. Some features of Cushing syndrome, pheochromocytoma can be found. Those are not important at the moment because we will discuss these endocrine conditions in our endocrine class. Now, 2 other things, malignant hypertension and refractory hypertension. So malignant hypertension is if a patient's diastolic blood pressure is above 120 and they have got retinopathy or nephropathy. Refractory hypertension is blood pressure above 140/90 despite maximum dose of 2 drugs for 3 to 4 months. So if you have tried 2 commonly used medication with their maximum dose for at least 3 months or 4 months, still blood pressure is above 140/90, that's refractory hypertension. Now, renal artery stenosis, which means that if you see this one, this is the abdominal aorta, and that's the renal artery which supplies your kidney. like this. And sometimes atherosclerosis can form this kind of plaque here, and it can cause like reduction of blood flow into the kidney, and that can end up causing hypertension. So in elderly population, atherosclerosis is the main cause, but sometimes in young adult, there is another condition called fibromuscular dysplasia, which can be a cause of renal artery stenosis also. Now, for renal artery stenosis, if you suspect this patient can have this, you have to do a Doppler ultrasound of the renal artery. And Doppler ultrasound can confirm the diagnosis of renal artery stenosis. Okay. Now, if renal artery stenosis is the diagnosis, your first line management will be ACE inhibitor or ARB. All right. Detection of hypertension. So as we discussed that a single visit cannot make the diagnosis of hypertension. Initial raised BP reading should be confirmed on at least 2 other visits within a space of 3 months. Okay. BP measurement is screening. So everyone who is above 18 should have their BP check every 2 yearly. So that's one of the questions that come in exam. Now, how we manage this patient? Not every patient who has got a hypertension will need a medication. That's a common mistake that we do. Like someone, maybe a 30-year-old male coming to you with blood pressure 150/90, and you just gave her medication on the first visit. That is so wrong. So there is a lot of things that you have to decide before giving a medication. So see in here, if the blood pressure is less than 120/80, you don't need to do anything, just recheck the blood pressure in 2 years. If it is between 120/120 to 139 and diastolic up to 89, that means the high normal. In high normal, we check in 1 year and advise some lifestyle modification. If it is grade 1, so up to 159 systolic and up to 99 diastolic, you can confirm within 2 months. So do another blood pressure checkup in 2 months' time and ask the patient to continue lifestyle modification. Grade 2, up to 179 and up to 109 diastolic, evaluate the patient within 1 month with lifestyle advice. So it's still up to this. You don't need to start the medication straight away, but you give 1 month time for the patient to do some modification. Even after 1 month, blood pressure looking like this, you can start the medication for the patient. Only time it is indicated, even in the first visit, to start the blood pressure medication is this one. So either you can see the patient within a week, and if you feel no, this is not, like you are not very comfortable with that, you can start the patient with antihypertensive in this case. Okay, but you have to do multiple time reading before you think that yes, this is the right blood pressure reading. So that's the main management that comes in exam, and you can get tricked in the exam that they have given a patient having a high blood pressure of 160/100, and you have done multiple readings. This is still the same, and if you choose to start the medication straight away, that's wrong. And not only just this, there are a few other things that we check before giving the blood pressure medication. So we will come into that. So you can see if mild hypertension observation with repeated measurement over 3 to 6 months is ideal before starting the treatment. Initial diastolic BP above 115, particularly patient with organ damage, may need immediate drug therapy. There is an investigation that we can do that's called 24-hour ambulatory blood pressure monitoring. So what is that? Sometimes you will find out that patients, when they are in your in your office, their blood pressure is very high, maybe 160 by 110. But when they go home, their blood pressure is 120 by 80. So when there is a marked discrepancy between office BP and home BP, then you're not sure which one is right. In that case, you do this 24-hour ambulatory blood pressure monitoring. So the patient will put a device, which is a blood pressure cuff on their arm. And throughout the 24-hour, patient will do the usual work and everything. This blood pressure device will monitor the patient's blood pressure, and then an average blood pressure will be given after 24 hours. Okay? And if that confirms patient having high blood pressure, you can say this patient is hypertensive. Few other things that can be done, that if you have done office BP, but two readings are markedly variable, like at one point you have found 140 by 80, other day you have found 190 by 80. When there is a marked discrepancy like this, then you can also do this 24-hour monitoring. And then there are others you can also do this. Okay, now always lifestyle modification is the first management in most of the cases. If the average diastolic pressure is 90 to 100, there is no evidence of organ damage, non-pharmacological therapy is indicated for at least 3 months without use of antihypertensive. Okay. What are the behavioral intervention that we can do? Most important is a reduction of weight. Okay. Even a little bit of, like every 1 kilo weight loss can reduce the blood pressure by 2.5 millimeter systolic, 1.5 millimeter diastolic. So blood pressure reduction, it depends a lot on weight reduction. So that's the first thing. Excess alcohol intake should be reduced. Reduction of salt intake. Then some exercise, reduction of smoking or stopping smoking. These are all important lifestyle advice. Now this chart is also important. So as I was saying, that it's not only the blood pressure that we look at. If a patient has got hypertension diagnosed over several occasions, lifestyle advice is must, but you have to also do this 5-yearly cardiovascular risk assessment. Remember that in our question solve class, I have shown you this cardiovascular risk assessment. In that risk assessment, if patient is low risk, that means 10% is their risk, you can easily do a lifestyle change for even 6 to 12 months. For moderate risk, still 3 to 6 months you can do it. And for high risk patient, ideally you can start the treatment immediately with lifestyle advice. So that's one of the other things, that you do the cardiovascular assessment. Based on how risk they are, you can just try lifestyle advice, or you can even start the treatment. Okay, so 2 things is important before starting the medication. One is how bad is the hypertension and how risky is this patient. Based on that, you will decide. Treatment. In starting medication, the first line medication above 55 years of age is either an ACE inhibitor or ARB. If ACE inhibitor or ARB doesn't work, then you can add a calcium channel blocker. Still not working, then thiazide diuretics will be your choice. Okay, so ARB, calcium channel blocker, diuretics. So ACD, that's your initial medication. Now you can try with any of these 3 at first. If target blood pressure is not reached after 3 months, then you start to do combination. So you can combine ACE inhibitor with calcium channel blocker. You can combine ACE with diuretics. You can even combine ACE with beta blocker. If even after this combination, after 3 months, still blood pressure is high, you can just add all these 3 together. Still not better, then you can add a spironolactone. Still not better, then specialist advice. Okay. So that's how step by step blood pressure medication has to be started every 3 monthly. And relatively ineffective combinations are, we normally don't just give calcium channel blocker and diuretics. These are not very good combination. And try not to give beta blocker and calcium channel blocker, which means rate limiting calcium channel blocker at the same time, because both beta blocker and rate limiting CCBs can reduce the heart rate quite significantly, causing heart block. Also better to avoid spironolactone with ACE inhibitor. It is hard to avoid it in some cases. It's not that you can't use these two. If you use these two, you have to monitor for hyperkalemia. Now, you will find out that not all the time you will always start the patient with ACE inhibitor. You always choose the right medication based on the comorbidities patient having. Like if a patient has got asthma, COPD, you would not give them beta blocker because beta blocker can cause bronchospasm. So for them, any others like ACE inhibitors, diuretics, CCBs, any of them is fine, but not the beta blocker. Same, someone who is having bradycardia, you would avoid rate limiting calcium channel blocker, right? You would avoid beta blocker. Same with heart block patient. For cardiac failure patient, we try to be careful before starting the calcium channel blocker. For diabetes, thiazide diuretics is not ideal. Best is ACE inhibitor. Someone who is suffering from lots of gout attack, thiazide is not best. What is best, ACE or ARB? Someone who is having peripheral vascular disease, if you give beta blocker, they will get more spasm of the arteries. So for them, better is something which causes vasodilation like calcium channel blocker. For pregnancy, ACE inhibitor, diuretics, these are not, we don't use it. The common ones are methyl dopa or calcium channel blocker. For renal artery stenosis, ideally ACE inhibitor, if there is, so we call it, if there is single renal artery stenosis, then ACE inhibitor is best. If bilateral renal artery stenosis, then ideally calcium channel blocker will be your best medication. Okay, so this is also important for exam because they will give you a scenario with multiple comorbidities for the patient, and they will ask you what is the right antihypertensive for this patient. So you have to know that which medication we would avoid in a particular group of patients. Okay, clear everyone? Now, the only thing that we haven't discussed from cardiology is palpitation, which is chapter 70 in John Mutta. And palpitation chapter covers all those important topics, which is your SVT, atrial fibrillation, atrial flutter. So those are also very important for exam. We will discuss a little bit about those in our question solve class, which is coming up with you. And mostly we will discuss those in our ECG class because those are related. Okay. Other than that, if you know up to what we have done, it's more than enough for cardiology. Now, there is no major difference between John Murtagh 7 and 8, but there are a lot of addition and things. I would not recommend anyone to continue reading 7th edition because 8th edition it's almost now 2 years it is out. So obviously for your preparation you have to get 8th edition. Dyslipidemia. So for dyslipidemia there is not much to discuss. We discuss that in our question solve classes when it comes. Okay. And what is the place of anticoagulation therapy in ST elevated MI? So if we are like, what is anticoagulation? So obviously aspirin, clopidogrel, those are antiplatelets. So we know where we use those. Anticoagulation comes with warfarin. So warfarin has no role in ST elevated MI. Then you have heparin or enoxaparin that we have discussed that in non-ST elevated MI we use that, otherwise we don't. So not much. And in ST elevated MI, it is mainly thrombolytics or you go for PCI. That's the main management. And Dr. Gina, guidelines, your John Murtagh is the best guideline at the moment. And for any kind of medicine related, RACGP guideline is best. Now, I know the topics are lengthy, but those are updated and very well written. You don't need to read each and everything. As I said in the first class, the main thing is that understand how is the common features of a condition, what is your initial investigation, what's your best investigation, and just get a basic idea about the management. That's it. Okay, it is lengthy to read, but the information that you need to retain is very less. Okay, so we'll be finishing it here tonight. Now, is there any questions about our ongoing course? So most of you know that the course has already started on 8th of October, and we have been now doing the 2 weeks free sessions for everyone. So the 2 weeks free session is almost at the end. There is only another 1 week, I think. So I hope that you are enjoying our session so far. I can see that a lot of you already been enrolled into the course. I'm hoping that you have got access to the portal, started reading the topics that we are finishing. Now, if any of you have any questions about the course, feel free to ask me, and I'm going to just go through a little bit about the course because many of you are asking me to discuss about the course details and everything. So let me just open up. So if you go to our website, that's firstaidamc.com. So this is our website, as you can see, firstaidamc.com. If you go to the website, you will be seeing this website opening. Now, if you come down, so this is our 5 months extensive MCQ course. So if you click over there, you will get the full course details and each and everything that you need to know about it. So we already took a trial class. The free class is running at the moment. You have got the schedule, and we are actually now over here, right? So you have 3 more classes with us, and we are giving the recordings of these classes in your Facebook group, in the YouTube. So in case any of you miss it, you can always go through that. The basic summary about the course is that we cover all the theory, as you can see. After theory, we do question solve on that theory. So you'll be getting the cardiology question solve. We also do sample question discussion, which you are going to get tomorrow. So 14th October. So Dr. Rabia is going to do a question solve class with you tomorrow at the same time. So make sure you join that class. Very interesting class. So we do the 6-year sample question discussion starting from 2018. But do we need all of those? No. If you know at least 2023, 2024, that's more than enough for your exam. Okay. So we advise to go through at least 6 to 12 months of recent questions to get an update about the exam and everything, get an updated topics that's important for exam. Now, you will be getting, now what we have done is that it's a very, very comprehensive MCQ class we have designed for you. Previously, we took 2 theory class and one question solve class every week. But now we are trying to add another question solve. So 4 classes in a week, 2 theory, 2 question solve, which is, I don't know, like if any course with this minimal price can offer this, but that will be a great addition for your course. We have never done this before. This is a trial thing to see how it helps our students. Hopefully you will like it. And we have added also a few other mentors so that everyone can help you to solve the questions accordingly. And I'm hoping that this will be really helpful for everyone. And also, apart from question discussion, you get a software which has everything that you need for the exam. Lots of questions with solved answers, lots of mock tests. We add mock tests every month. There are already 150 question grand mock tests in our portal, and we're trying to add another one. So you'll be getting 150 questions, like a full AMC exam, which is like, I don't know, like if anyone has it in Australian courses, but you will be getting it as well. And also, all of these things we have discussed with you, that we give recordings of every classes after the class, and also you get access to the notes until you pass. So this is like a very comprehensive course for AMC MCQ. And I'm hoping that if you finish the course appropriately, give your time, do the hard work, there is no way you can fail this exam. Okay? But no one can guarantee that, yes, you do the course and you will pass it. You have to do your work. You have to study. You have to do all the things that a past candidate should do. Then only you can get the help. Okay? So as I said, we will be covering the complete theory-based question discussion. And then in the software, you can get theory-based mock exam. Like if you have got the access, you will see a cardiology mock test. So get the mock test after our ECG class. Then you get the sample question discussion. So we can't discuss 6 years in your course. We'll be mainly focusing on the recent ones, and we'll be giving recordings of the other years. Okay, like maybe 21, 2022, those will be recordings. 2023, 2024, we'll be discussing in your class. Okay. And obviously mock test will be added, and there is a huge amount of mock test already there. QBank is there, extra classes on ECG, imaging, CTG, stat, ethics, everything that you need. Recordings are there, as we said. All the soft copy of the books will be provided. Okay, and if any of you don't have 5 months before your exam, let's say this year is your exam, we provide all the recordings of our previous batch, the one that we just finished. And if you are running out of time, you can always just do that from your course, because we give the recording. You can just finish it in your own pace, and that's also enough for your exam. Okay, so that's all about the course. Any question, guys? So course will be till what date? So I can't definitely give you the end date, because it depends how we progress, but it is a 5 months course. So if we start in October, just add 5 months and that will be the case. And should we go through the theory classes only to study, or should we go through the books? I always say that theory classes are more than enough, especially for cardiology. There is nothing else that you need to do, but there will be few things which we will ask you to read from the books that you should do. Okay. Now about any of the QBank, if you like, obviously we are not Amidex or M+X. If you want to buy those, that's up to you. We are not part of any of these QBanks, so we can't comment on those. But I would say you don't need to, because we provide some of the QBanks that will be enough for you. But if you want to buy those, that's really fine. After learning from this lecture and JM, do we need to read from RACGP? Now, the one that is important, we will ask you to read. Like for pulmonary embolism, we would ask you to read it from RACGP, obviously, even after the class. So there are some important topics which you should read. This 2 weeks class will not be repeated again, because this is a part of the class. No, it's not cardiology question tomorrow. So tomorrow will be just a random question solvation, and after that class, that will be cardiology question. All right, everyone. So that's it for tonight. Thank you, everyone. Don't forget that you have a class tomorrow. Okay. Thanks. Bye. Take care.